Thank you so much for having me here today on the OHDSI call. My name is Elizabeth Sherwin. I am a biostatistician at the Stanford University School of Medicine, which is part of the PRISM, is one of the centers of excellence from the Improve initiative that Paul just mentioned. And I was brand new to OHDSI when I started the Maternal Health Data Science Fellowship last fall. And then I had the opportunity to attend the symposium in New Jersey in October, which was just great to hear more about what I had been learning and meet some of you in person, and then really see how passionate the OHDSI community is and how important it is to be doing these network studies. So as Paul mentioned, this is a work in progress, but I'll be sharing with you some of the work that we've been doing on severe maternal morbidity among pregnant people with congenital heart disease. So severe maternal morbidity includes outcomes of labor and delivery that are unexpected and can result in significant short or long-term health consequences. Some of the categories of SMM are shown in this figure, and it's often studied alongside maternal mortality as it's more common than mortality, and it's really important to understand these events so that we can better prevent them and identify them quickly when they do happen to make birth safer, pregnancy and delivery safer for all birthing people. Congenital heart disease is a category of cardiac conditions present at birth. I've shown just 3 on the slide here, but there's many. And thanks to improvements in diagnosis and treatment, there are more adults today living with congenital heart disease. So some background for our study. Studies have shown that heart disease is associated with severe maternal morbidity. Few studies separate out congenital heart disease from other types of acquired heart disease, and congenital heart disease is likely underreported in large databases, partially given the time between diagnosis in childhood and then pregnancy in adulthood. And more people with congenital heart disease are surviving childhood to reach reproductive age. So our study has 2 objectives. One is a cohort characterization question where we want to describe the pregnant population with congenital heart disease. So what are their diagnoses and their demographics, comorbidities, and then start to descriptively look at their severe maternal morbidity indicators. And then our second objective is a population level estimation question. So do patients with congenital heart disease have an increased risk of SMM compared to those without? So our target cohort is women with a diagnosis of congenital heart disease prior to delivery, and then our comparator cohort is women without congenital heart disease. And our outcome is severe maternal morbidity, which we'll look at from 1 month before delivery to both 6 weeks postpartum as well as 6 months postpartum. So I'll share a little bit about how we created our cohorts in Atlas. So first we need to create a concept set of congenital heart disease. We did see that there's this one standard concept for congenital heart disease with 884 descendants, but we didn't want to just use that because we wanted to make sure we weren't missing anything that might not be included. So we started by building our own concept set. So we looked in the literature to see how people were defining congenital heart disease, especially in other studies related to pregnancy. So we created this list of ICD-10 codes and then built our concept set from there. So kind of to give you an example of how we did this, we searched the ICD-10 code Q21 in Athena, and then we could see, okay, that maps to the standard concept of congenital septal defect of the heart. And then we included that as well as its descendants in our concept set. So when we did that for each of our ICD-10 codes, we ended up with a very large concept set of only 10 standard concepts at first, but with about 1,000 descendants or total concepts. So we exported that into a CSV file like this, and then mapped it back to all of those ICD-10 codes at like the most granular level, just to make sure we weren't missing anything. And another way we made sure we weren't missing any concepts was we used this compare feature in Atlas. So you can put in two concept sets. So the top one is the concepts that we built, and then the second one is the standard concept for congenital heart disease and all its descendants. And then we were able to see which concepts are in both, or one only or two only. So that was another way for us to make sure we weren't missing anything, or maybe we included something we shouldn't have, and we reviewed that with a pediatric cardiology clinician. So that's how we ended up with our final concept set, which has 17 concepts and then about around 1,000 total. Only less than 100 of those 1,000 concepts actually have record counts at our site. So it's not quite that many, but we wanted to include the other ones just in case other sites are using some of the concepts that we're not. So now that we had our concept set for congenital heart disease, we needed to make one for people who delivered. So we ended up using procedure codes for deliveries. We found that currently that seems like the best way to identify people who actually gave birth at our institution, but we're actively working on creating a more robust process in the OMOP CDM to accurately identify and label pregnancy episodes in EHR data. So then using these concepts, we created our cohorts. So people needed to have a delivery procedure, be female and between the age of 12 and 55 at the time of delivery, and then have at least one condition occurrence of congenital heart disease anytime prior to delivery. And then our comparator cohort is the same as this one, except with 0 occurrences of congenital heart disease. So these are the number of deliveries that we see at the two sites we've run our data at so far. So around 900 deliveries with people with congenital heart disease, and then 35 to 50,000 deliveries among people without congenital heart disease. And I say deliveries because people could have had multiple deliveries. And so the 900 deliveries represents about 800 people. But it's just easier for the sake of this presentation to show the total number of deliveries rather than the number of people. And these are some demographics. So on the left, you see deliveries among people with congenital heart disease at our two sites, and then on the right, people without congenital heart disease. So I think this really highlights the strength of doing these network studies, just the geographic and demographic diversity of the study populations. And then these are our top congenital heart disease diagnoses in the congenital heart disease cohort. It's pretty reassuring because ventricular septal defect and atrial septal defect are the most common congenital heart disease conditions. Like those are known to be the most common, and that's what we're seeing in our cohorts too, which is good. And then lastly, I'm going to briefly talk about severe maternal morbidity. So we'll be using the concept set that Stephanie Leonard created as a part of the PREG work group. And she also presented some of her results at the OHDSI Global Symposium last year. So Stephanie created this by searching for the 20 SMM indicators as defined by the CDC and Atlas, and then created this concept set of conditions and procedures. And so I just ran a characterization in Atlas to descriptively see the numbers for SMM in each cohort. So you can see that about 4 to 6% of deliveries among people with congenital heart disease have SMM, compared to about 2% of deliveries without congenital heart disease. We know that in kind of the general obstetric population in the United States, SMM occurs in about 1% of deliveries. So here we're seeing it's a little bit higher, but I think that's to be expected as our sites are referral centers for high-risk pregnancies. So our next steps, we've been finalizing the protocol, and we need to set up the analysis and then invite other sites to participate. So I want to say a huge thanks to all of our other team members and the other maternal health fellows on the team. And thank you so much to our data partners, Johns Hopkins and Stanford. And thank you to the Improve Initiative, the Maternal Health Data Science Fellowship, and the OHDSI community for supporting this work.